be caused by structural, chemical, or electrical abnormality in the nervous system. And these are the, globally divided by one neurology. But what we need to understand about neurological disorder and what are the crucial, why it is crucial, that it is crucial because of several reasons. Because it facilitates development of effective treatment, enables early detection and intervention, addresses public health implications, drives scientific research and innovation, support patient and caregivers, reduces the stigma, enhances education and training for healthcare profession, and promote brain health and preventive measures. So therefore, we need to understand all the neurological disorder. And if we look at various disorders which can be divided into the subgroups in the brain, like cerebrovascular accident, which can be hemorrhagic stroke, thrombotic embolism, or even the subarachnoid hemorrhage because of aneurysm. Neurological infection may be viral, bacterial, parasitical in certain part of the Africa. Headache and facial pains, which can be many, starting from primary headache, migraine, cluster headache, tension type headache, and then of course the secondary headache may be due to the raised intracranial pressure or meningeal irritation, arteritis, trigeminal neuralgia, post-herpetic neuralgia. And look at the degenerative disorder, most common being Parkinson's disease and Alzheimer's disease, but you can also have demyelinating disorder like multiple sclerosis and genetic disorder. Disorder of developments, which can be metabolic, Down syndrome, genetic, toxic, and seizure disorder, which is a very big classification, partial, secondary, generalized, and generalized seizure, absent seizure, etc. And the tumors, which can be benign or the malignant. So what are the various common neurological conditions? And we start with Alzheimer's disease, which is a progressive neurodegenerative disorder characterized by memory loss, cognitive decline, and behavioral changes. You have Parkinson's disease, which is a movement disorder caused by the degeneration of dopamine-producing neurons in the basal ganglia, leading to tremor, stiffness, impaired balance, and coordination. You have multiple sclerosis, which is an autoimmune disorder where the immune system attacks the protective covering of nerve fiber, that is a myelin, leading to the communication problem between the brain and rest of the body. You have an epilepsy, which is a common neurological disorder because of electric disturbance in the brain, and it can be very widely and different manifestation. You have migraine, which is a primary headache, recurrent, moderate to severe headache, accompanied by other symptoms like nausea, vomiting, photophobia, and phonophobia. Then you have a stroke, which is sudden interruption of blood flow to the brain, leading to the damage of the brain tissue, resulting in various neurological deficits depending on the affected area of brain, and major cause of death as well as disability all across the world. Amyotrophic lateral sclerosis, which is a progressive neurodegenerative disease affecting nerve cells in the brain and the spinal cord, leading to muscle weakness, paralysis, ultimately the respiratory and bulbar failure. We can also classify under the motor neuron disease. Then you have neuropathy, where there is damage to the peripheral nerve, resulting in symptoms such as pain, numbness, tingling, and weakness, which usually in distal pattern affect the hand and feet. And you have myopathy, where the muscles are involved and which could be proximal, distal, degenerative, inherited, or even the infective like polymyositis. So you can have common causes of neurological disorder. Once again, establish genetic factor like Huntington's disease, environment factor like lead toxicity can be seen in children and even adult, or occupational hazard, infection like meningitis, encephalitis, trauma, which could be very common, traumatic brain injury, giving rise to brain or spinal cord involvement, autoimmune disorder, which can be encephalitis, multiple sclerosis, and others, degenerative disorder, as we already discussed, vascular we already discussed, but metabolic disorder are a big factor like diabetes, renal failure, etc. Let's talk about each disease in one or two slides, and let's understand about that. Stroke is most common. It is a serious condition, and it's an incident where there is a disruption of blood flow, as I already mentioned. Ischemic stroke are much more common, 85%, but the hemorrhagic stroke can be 15%. Among the global burden of disease study, stroke is the leading cause of death and disability worldwide, and its prevalence is high in low and middle income country, including those of South Asia like India. And in India, the typically it is 10-year younger patients are involved as compared to the other part of the world. The prevalence of stroke varies from 44.54 to 150 per 100,000 people, and the cumulative incidence ranges from 105 to 152 per 100,000 people per year. And these numbers are higher than those in high-income countries. The study by one of the study from China, which is published recently, was analysis of ischemic stroke burden in Asia from 1990 to 29, which was based on global burden of disease. And they looked at all age, sex, the number of cases, and they studied over a period of time about the age-related risk factor and the burden of disease. And what we got on this study is the burden of ischemic stroke exists substantially and exhibit variation in the aspect of age, gender, and geographical region in Asia without targeted implementation of population-wide primary strategy for prevention and control. And the burden of ischemic stroke is likely to worsen significantly in the future. And there was a time when we were thinking that women are not as well affected, but here, when we have looked into the daily, and while the women are equally affected in the stroke in Asia as compared to the men. Let's talk about epilepsy, which is a continued trigger seizure where more than 2 epileptic seizure causes seizure disorder. It is an electric activity in the brain, which is which is about 1% of adult, which affects, and it can affect on any age. And India and other developing country, it estimate from 3 to 11.9 per 1,000 people. Alzheimer's is the slow deterioration of cognitive function due to the degradation of neuron and synapses. There is accumulation of the filament in the brain, and it's a related kind of dementia which is becoming a public health concern because the geriatric population is emerging in emerging nation is increasing. And as you know that even longevity in this part of the world has been rising. So there is an increased incidence of Alzheimer's disease. And according to recent updates, almost 14.2% of world population aged 60 and over, those who are residing in developing nations, making up almost 70% of the total prevalence for this disease. Parkinson's disease is a disease which is due to the dopaminergic neuronal loss with the presence of alpha-synuclein protein accumulation in the brain. And it is usually caused motor and non-motor symptoms such as bradykinesia, tremor, stiffness, postural instability, olfactory dysfunction, constipation, and in some patients, cognitive disability and the sleep problems. The prevalence of Parkinson's disease is 120 per 100,000 in India and other developing countries. ALS is another disease which is degenerative, and at present we do not have any treatment for ALS, very debilitating. Annual rate of ALS is about 1.5 to 2.7 per 100,000 and prevalence is 3 to 5 per 100,000 respectively. And it can involve the spinal onset, development of limb muscle weakness, start from hand, the wasting and fasciculation in the hand, and that can progress to the tongue. Bulbar effect causes dysphagia, dysarthria, and when respiratory muscles are involved, many of these patients in terminal state need ventilator and the support for the feeding. Traumatic brain injury is when the external forces causes damage to the brain, leading to wide range of physical, cognitive, and emotional impairment. India is the capital of the traumatic brain injury with over 1 million people suffering from serious TBIs and about 100,000 lives are lost annually. Leading cause of TBI is road traffic accident, which account for 60% of the TBI, followed by the fall, violence, alcohol, which also is present in 15 to 20% of TBIs. The areas of brain impacted by the TBI can be seen usually frontal and the temporal lobe are more sensitive. Beyond the immediate physical and cognitive impairment, TBI can lead to long-term disability, impacting employment, education, and the daily function. It can affect mood and feeling, behavioral, cognitive, and it can also cause perception disturbance. Interpersonal relationship can affect it. So they are the cognitive part of the effect which can be affected. Family often faces emotional and financial strain as they negativate the complexity of caregiver and the rehabilitation. And the more important thing is the traffic accident are usually affecting the young people. That's the reason family loses somebody who has been actively working or the breadwinner of their family. The social burden includes healthcare costs, lost productivity, and the need for the support service. Multiple sclerosis is a chronic autoimmune disease that affects the CNS, including brain and spinal cord. It occurs when the immune system mistakenly attacks the myelin sheath, the protective covering of the nerve fiber, leading to the inflammation, scarring, and disruption in the nerve signaling. Symptoms may vary widely, can include fatigue, numbness, weakness, difficulty with coordination, balance, visual involvement because of optic nerve involvement, and the long-term when brain atrophy occur, cognitive impairment. The more common is it affects the young female more than the male. In Asia, particularly, opticospinal variant is common and need to look for neuromyelitic optica syndrome, which can be there when the spinal cord and optic nerves are involved. It's typically diagnosed between 20 and 40 years of age, can vary greatly in severity and progression from person to a person. You can have relapsing and remitting. The prevalence of MS in Asia and Oceania is 37.89 per 100,000 people, with an incidence of 2.4 per 100,000 people. While there is currently many therapies available for MS, treatment aims to manage symptoms, slow disease progression, and improve the quality of life for the affected people. So ongoing research is continued to explore new therapy, including the stem cell therapy, which is supposed to reverse the demyelination and better understand the underlying mechanism of disease. And we are seeing more and more disease-modifying drug today being used to cure the multiple sclerosis. The recent article, which has been challenges in the neurological practice in developing country, was a very interesting, which suggested that how the burden of neurological illness in much higher in developing country as compared to the country, because mainly the factors are like poverty, malnutrition, and even the lack of neurologists, primary care physician, and the guidelines through the general physicians for lacking. And therefore, it is very important that this paper, of course, was from India, and they stress upon how the sub-Sahara Africa and other part of the low and middle income countries has challenges in dealing with the neurological practice or neurological disorder. The recent paper on global, regional, and national burden of neurological disorder in 204 countries and territories worldwide were very important, from Huang and Lee et al. And this paper, which has compared over 2009 to 2019, that how the neurological disorder has moved away, and it emphasized that there is a need to control the increase in age standardized incidence rate of neurological disorder in East Asia, tropical Latin America, southern Latin America, and Western Europe, particularly in China, Ecuador, and Italy. And I'll go through some of these paper. You can see that age standard incident rate is being higher in certain part like China and certain part of the Europe, which they have emphasized upon. Same way, the number of cases which has been seen with the daily due to the ischemic stroke in different country in Asia in 2019, and you can see age standard prevalence age standardized mortality rate, disability adjusted life years, and age standardized disability adjusted life years. Again, Asia, it is high, particularly in the East Asia compared to the other part of the world, and which is a little worrisome for us, and we need to look into that. And you can also see that various other countries, how they are faring in these races. And some of the countries are having low incidence, but many other countries are having high incidence as been listed here. We can also see that how at particular age the diseases has been progressing. And if you could see that as age advances, you can see that Alzheimer's and the stroke has a higher incidence as compared to the other, which is like headache, depression. These are the bipolar disorder, headache disorder are much more common incidence as compared to the daily, which affects the Alzheimer's and the stroke. So these are some of the neurological disorder, which are very common, and they are shown in this particular paper. And this daily also between the world and the low middle income countries, and the death between the world and the low income country or low middle income country, you can see that cerebrovascular accident, Alzheimer's disease, epilepsy, there is still, and the infection like Japanese encephalitis, they also still form a challenge for the low income country or the low middle income country. So infection, stroke, they are much more common compared to the Alzheimer's disease, which is much common in the other part of the world. So the conclusion of GBD survey on neurological rehabilitation from 1990 to 2019, that the burden of neurological disorders significantly differed between countries and the region. However, due to the aging of population, the number of incident and daily cases are increasing significantly. And due to the current limitation in medical resources and health system, this burden remains an important challenge globally as well as locally. Future efforts should target older adults and women, while improved strategy to control modified risk factor, which including high fasting plasma sugar, which is come as one, and high body mass index, could be used to effectively decrease the associated daily. So pre-diabetic, diabetic, and obesity has come out as a two common factor which need to be taken care in this country. International organizations and governments should strive to narrow the gap between the countries at different level of development according to their most prevalent neurological disorder and their associated risk factor. Let's talk something about the disability before Dr. Farikhan takes over on this talk. What does it mean? Nation, it is loss of daily. Organization, it is investment. Physician, it is investigation and intervention. For patient, it is end of the road. And for caregiver, it is the beginning of a burden. So that's how it is really affecting. And these are the all various neurological disorder which is affecting family and the society. So how do we have a rehabilitation approach? Rehabilitation will play a crucial role in managing neurological disorder by helping individuals maximize their functional abilities, improve quality of life, and regain independence after injury or illness. And this interdisciplinary approach involves a team of healthcare professionals working collaboratively to address the diverse needs of patients with neurological condition. And you can see that how the team is going to work together like a cogwheel to join with each other. This is the team which we can do together, we can do better. So the models could be medical model without a formal team, which can be service delivery model, or multidisciplinary like a pyramid, interdisciplinary like a matrix, or transdisciplinary, which is a cross treatment. So features of rehabilitation should be shared commitment, psychological attachment to team, shared team identity, the understanding of and meaning given to the team by other healthcare professional and presumably the public and people in the organization. Shared and explicit team goals, giving the team a clear purpose, agreed roles and responsibility, delineating the unique and shared area of authority within the team, interdependence between team members, both when making decisions and when undertaking action, integration of work with team members, focusing upon the team's goal generally and specifically. I know you all are doing already this, but it's just to briefly mention that this is how the team should work. And they should have a goal, which is maximizing functional independence in activity of daily living, improving mobility, balance, motor function, enhancing communication skill, and overcoming speech and language difficulty depending upon the modality being involved, managing cognitive impairment and promoting cognitive function, addressing emotional and psychosocial need, including mood disturbance and adjustment to disability, preventing secondary complication associated with primary neurological disorder, facilitating community reintegration and participation in social, recreational, and vocational activity. It is important to having a patient-centered goal because it can optimize your outcome by aligning intervention with individual circumstances, empowering patient to actively participate in the care, enhancing adherence to treatment plan, addressing diversity and individual differences, improving patient satisfaction and experience, minimizing unnecessary intervention, and promoting holistic care by considering physical, psychosocial, psychological, social, emotional need. And patient also understand that everybody is concerned about him and therefore he needs to put in more effort. So impact of neuro rehab would be functional improvement, reduction of secondary complication, reduction of crisis admission to the hospital, because you can prevent many complications like pulmonary embolism, deep vein thrombosis, bad sore, etc. Better coordination and use of resources, improve opportunity for education, training, and research, and early return to work with a better quality of life. But what are the challenges which we face in the neurological rehabilitation? We have heterogeneity of condition. As I explained you, the neurological disorder are too many, and there is a complexity of symptoms. Diseases like multiple sclerosis, traumatic brain injury affect multiple systems, chronicity and long-term management, functional limitation and disability, psychosocial impact, cognitive and communication barrier, resource constraint, and comorbidity and multimorbidity. So what are the challenges to provide neuro rehabilitation in countries like India and other developing countries? We have limited access to specialized service. We have shortage of skilled healthcare professionals. We have financial constraint and affordability issue. We have limited awareness and education about neurological disorder and rehabilitation. We have inadequate infrastructure and equipment. We have geographical and culture barrier. In India, you travel 150 kilometers and you have a different language, different culture. You have language and communication challenges. You have socioeconomic factors such as poverty and lack of support system. And on top of it, there's an out-of-pocket financial issue, which is most of the patients are paying, 84% patients are paying out of pocket. And therefore, government need to come out with a program for the insurance to cover the neuro rehabilitation. And we are trying our hard to get at least 1 year being covered with the insurance for the rehabilitation after the injury. So what are the solutions? We need to expand training program for rehab professionals, and Asian Oceanian Society is trying that if we can build up a system for education for people in this part of the world to have a training program regularly, and with the help of WFNR, we'll definitely establish some of the training center in this part of the world. Invest in infrastructure and equipment, promote community-based rehabilitation, and involve family as a part of family-based rehab, raise awareness through public education campaign, provide financial support or subsidies for neuro rehab services, enhance interdisciplinary collaboration among healthcare professionals, address culture sensitivities and belief surrounding the disability, utilize the telemedicine for remote access to neuro rehab services, advocate for policy reform to prioritize the neuro rehabilitation, and promote research and innovation in the neuro rehabilitation. So to summarize, neurological disorders are second most cause of mortality, and many of them do not have cure or complete recovery. Many of the degenerative disorders like Alzheimer's disease or Parkinson's disease are progressive and needs to intervene with the treatment at all the time. Disability following stroke, TBI, and MS is significant and may not reverse in spite of the treatment. Rehabilitation become a mainstay of neurological disorder, which may be multidisciplinary, tailored to individual need, maximize the functional independence in daily activity, mobility, communication, and cognition. Rehabilitation help individual adapt to and cope with challenges of neurological disorder. It reduces the disability, prevent complication, and improve the long-term outcomes. It empowers the active participation in care and foster autonomy. It facilitates community reintegration, and vocational rehabilitation intervention are evidence-based and evolving. Access to rehab services is essential for optimum outcome. There is a great need to strengthen the neurological rehabilitation, and both IFNR, AOSNR, and all other organizations involved in Asian Oceanian Society are committed to strengthen neurorehabilitation in this part of the world, and WFNR is always going to support this effort. We will have continue every month's webinar. You can register for all the webinars and you will get the information. The next webinar will be told at the end of the session. You are most welcome to come to the 13th World Congress for Neurorehabilitation, which is in Vancouver from 22nd to 25th May. If you are not able to visit physically, you can join the online. You can scan the QR code and register yourself. We have two more conferences coming in 25. IFNR Con will be in Ludhiana, organized by the President-elect Dr. Jairaj Pandian in April 2025. And we have the 6th Asian Oceanian Congress of Neurorehabilitation at Indonesia, Yogyakarta from 3rd to 6th September 25. You will soon see that IFNR is releasing the book, textbook in WFNR during the Vancouver Congress, and the journal which will be released on 1st of the June, the first issue of the IFNR. That note, I thank you very much to all of you and look forward to have your active participation. We'll definitely take question answer at the end of the session. I'll stop sharing.
Thank you. Thank you very much, Nirmal. That is very comprehensive. And the point of the disorders, the point of rehabilitation, the treatment is already encompassing. You practically summarize the whole of neurorehabilitation medicine. And that is very interesting. A lot of it is eye-opener also, especially the statistics on the Asia-Oceanian region. So we always say we're 60% of the world. So we can imagine that we're the most populous part of the world, and we have the brunt, the burden of most of these diseases in our area. And through this webinar, we are going to continually answer some of the problems of these conditions which we have in our region. We have another speaker, our President-elect. Fari, are you okay with your video?
Yeah, Smita, can you play the video, please?
Yes. If the videos... Can I introduce Fari first before the video? Professor Fari Khan, our President-elect, is the Director of Rehabilitation at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre in Victoria, Australia, elected Vice Chair of the International Society of Physical and Rehabilitation Medicine, inducted into the U.S. National Academy of Medicine, awarded the Member of Order of Australia for outstanding contributions to rehabilitation medicine and disability in 2022, recipient of the George Burniston Oration Medal of the RACP, and immediate past inaugural academic fellow on the board of Australian Faculty of Rehabilitation Medicine, Royal Australian College of Physicians, and elected board member of the Rehabilitation Medicine Society of Australia and New Zealand. She has over 20 years of experience in neurological cancer and trauma rehabilitation, set up evidence-based specialized rehabilitation programs, and awarded the Sydney Licht Award by the ISPRM in 2018, the Heimering Award in 2020, and the Joel DeLisa Lectureship Award in 2021. So let us warmly welcome our President-elect, Professor Fari Khan, to talk on the importance of rehabilitation in improving the quality of life. Professor Fari.
Arpita, please play the video.
Good morning from Melbourne. Thank you very much to the Indian Federation of Neurorehabilitation for inviting me to speak at your conference. Thank you to the organizing committee and all the members of the scientific committee. Thank you. Today I'm going to talk about integrating rehabilitation, prevention and maximizing function across the care continuum for patients which include neurorehabilitation. So I hope that I can share with you the Australian perspective and that you might have some learnings from that, and they might be able to be extrapolated to the Indian setting. So this is what I'm going to talk about, just a briefly overview of disability and aging and the healthy role of prehabilitation and rehabilitation for patients with neurological issues in the community. But mainly I'm going to focus on improving service delivery in people who have a disability and who are aging, and also give you examples in our service in rehabilitation across the care continuum as an enabler in the community. This is a photograph of the Royal Melbourne Hospital where I work, and you're very welcome to come and visit me here. So in the first section, this is just a one or two slides where I want to talk about aging and disability in the Asia Pacific region. This is particularly important for neurorehabilitation because, as you know, that globally the population is aging. But by the year 2050, 8 out of 10 elderly people will live in less developed regions, and that includes the Asia Pacific. And currently we have 53% of the world population over the age of 80, and this is projected to increase to just under 60%. So this is a huge issue for all of us. Similarly, the WHO and the UN, the Decade of the Aging, have come out with a number of processes for developing and maintaining the functional ability to enable well-being for the elderly people. And rehabilitation has been identified as a key strategy for health promotion, prevention, treatment to support the needs of a population. And this is in line with the SDG to ensure number 3, which is ensure healthy lives and promote well-being for people at all ages. And on the right-hand side, you'll see some of the facts listed on aging and health, which includes rehabilitation. This is a photograph of where I live in downtown Melbourne. It's just to give you a taste for what Melbourne is like. It's a very, very beautiful city. So in this section, I want to talk about neurorehabilitation service delivery as an enabler in the community. So when you think about healthy aging, you think about persons with disability, neurological disability, and then you think about those with aging and a neurological disability, because then aging process is enhanced and people decompensate earlier. Some of the lessons that we have learned from our inpatient rehabilitation practice is about clinical workflow and efficiencies. So for example, the way to move forward is to reduce the variation and standardization of the care processes in the community. And I'll give you an example of that later. But other issues are how you improve care and patient functional outcomes. And some of you are aware that initially mortality and mobility were considered key outcomes of a health intervention, or there are 2 pillars of health outcomes, mortality, mobility. But now the WHO has endorsed number 3. The number 3rd pillar is function. So mortality, mobility and function are now the 3 pillars of healthcare outcomes. Similarly, post-discharge follow-up, linkages with universal healthcare systems within the countries who do have universal healthcare, and other community and other support services. Then having evidence-based decision-making processes or establishing consistency in those processes. Appropriate and timely referrals, for example, to develop a health service, and how you can improve the patient from hospital to community is a huge priority in our part of the world. We often have booster episodes for people with, say, multiple sclerosis who may have secondary progressive MS, and how we want to keep them in the community and prevent their readmissions or representations to hospital. So we give them MS booster rehabilitation for, say, a couple of weeks to maximize their bladder or bowel, or relook at their cognitive strategies or physical therapies for spasticity, for example, and so forth. And booster rehab seems to work very well. Similarly, how can we enhance collaboration and coordination with primary care? And that's very, very important now. And as you know, with the WHO 2030 plan, primary care is a huge area that rehab medicine needs to work better, because patients will be in the community and we need the referral person, the GP, the family doctor, to be the main link who is referring to specialist services, including rehabilitation. The other very important area is that we need to look at patient-reported measures, outcome measures, and patient-reported experiences measures. And this is a big priority, because the patient-centered care or personalized care has been in rehabilitation since forever. But we don't seem to have those measures that measure what we do in terms of prems and proms. Other ways of reducing variation in healthcare service delivery: once you standardize the care processes, developing protocols, clinical guidelines, for example. So in our setup, as I said, for example, people have asthma action plans. So we have COPD action plans, we have MS action plans, we have stroke spasticity action plans, just to help patients cope with their problem in the community and not represent to the hospital emergency, because that is not convenient to patients nor the health service, if it can be managed better in the community in patients' own settings. Similarly, we have developed a lot of key performance indicators for best practice for neurorehabilitation, which include strategies to reduce hospital representations, reduce complications, for example. We have electronic medical record systems to drive best practice by using analytics. So, for example, patients who have brain tumors, for instance, they come to their online surgery school prior to their tumor resection, for instance, and this is all delivered online. We also have surgery school. We have a number of modules for patient education. Some patients can also, before they come into hospital, can actually log in and put in their own medical information and their wishes and what they expect prior to coming into hospital, so that when they're admitted, some of the information is already there. Similarly, patient journey boards, which is very important now if you are using electronic medical records, or even if you're not. Patient journey boards basically look at patients from community to hospital emergency to the unit service or the ward that they're in, and then into subacute system with its aged care or rehabilitation or community care and so forth. Similarly, another area that really would help strengthen what neurorehab does is work better with GPs and community supports. In Australia, we have the National Disability Insurance Scheme, which provides free of charge lifetime care for people with disability. It's all funded by the Australian tax systems. So we're one of the very lucky countries indeed. Other things include implementing strategies that make gaps and barriers for patients in the community. They help in reducing those barriers, whether we improve access to health services and to gyms and technology, for example. I've got the example of spinal cord injury gyms. So in Victoria, for example, people with spinal cord injury, even low paraplegia, were not able to go and exercise in the community because many of the gyms did not have gym instructors who were qualified or knew what to do with patients with spinal cord injury. So one of my colleagues did a whole program and upskilled a number of gym trainers so that they could then cope with people with disability, for example, spinal cord injury. And these patients now have the ability to go back in and to exercise and do what they need to do in the community. Similarly, using apps. I know in India the IT system is so advanced, so we have a number of apps for patients to access and report their mental, physical and other well-being, and we have apps for the doctors and general practitioners and family doctors to upskill them and for them to report back. A number of consumer forums, patient education forums are held virtually, and therefore people can use apps, etc. And of course, the new frontier for neurorehab, as in with other rehabilitation, is cybernetics and machine learning. So, for example, we can look at artificial intelligence and look at trajectories of recovery, or trajectories of patterns of recovery and coping in the community, for instance. This would be really exciting frontier for neurorehabilitation in the future. Another example I wanted to give you, for example, is our enhanced recovery after surgery program. So, for example, this is based at the Peter MacCallum Centre in Victoria, where I also head the rehabilitation service. And this is an example of colorectal service here, but it can also be used for brain tumors and other neurological tumors, where you have primary care doctors in the community, which are your family doctors, your GPs. They refer to an acute hospital service for surgery or for whatever patient may need. They are triaged initially by the triage nurses, and then they are referred to a specialist clinic, for example, rehabilitation anesthetics clinic for colorectal surgery. But these clinics have rehabilitation physicians who work hand in hand with the anesthetists and work hand in hand with palliative care and with general surgical services to have the patient as fit as best as they can prior to their surgical intervention or radiotherapy or whatever it might be planned for that patient. And then they are followed up at the ward and provided rehabilitation, and then right through to the community. And this is freshly funded. It's only 2 years down the track, and we're seeing very good outcomes from health service delivery programs such as this. Now, you're all familiar with prehabilitation. So, for example, people with brain tumors would be classically good for prehabilitation, for instance. Prehab is really how you can improve outcomes by targeting information for high-risk patients. So what sort of high-risk patients are we talking about? So, for example, people who have esophagectomies or major abdominal or chest resections like lung resections or pelvic resections, for example, or HIPEC procedures. And what does it mean? So on the left-hand side, you have the full medical assessments, anesthetist, surgical, oncology, rehab medicine. Then you have risk stratification using CPET or DASI and other outcome measures. And you look at the AKPS or sarcopenia testing, nutrition, psychology, but also we use ClinFit. And ClinFit is a universal ICF measure with 30 items, which is endorsed by the WHO, that gives you and I, as rehab physicians or rehab practitioners, physios, OTs, how to assess mobility, self-care, and other domains that are in our everyday lives. And we know that with prehabilitation, patients who have prehab have much better outcomes. They have reduced complications, they stay lesser in hospital, they are not readmitted, they cost less to the health service, and they have better fitness, cognition, and overall better quality of life. There's a lot of evidence, as you can see from these, for various forms of cancers and prehabilitation, and this is just there on the slide for you. Similarly, when you have personalized prehabilitation in high-risk patients who are having surgery, you can see that those who receive prehabilitation have a reduction in their complications by half compared with the control group, as you can see in the red box. Also, you see that the patients are very accepting of prehabilitation because it is personalized to them, it is available in a setting that's convenient to patients, and is being provided by professionals who are specialists in those areas and who know what they're talking about, and the interventions that are chosen are appropriate and as best possible evidence-based. Similarly, another example that we're doing at the moment is how we can embed rehabilitation in routine clinical practice. And here we're looking at functional snapshots. So here we are trying to use the ClinFit like a worksheet where everybody coming into hospital, like some places use a functional independence measure. We're also using the WHO ClinFit to look at what are the barriers, what are the facilitators, how can we use the best functional snapshot to design treatment for these patients. This is another example of the learning health systems model, which is hospital to community. And this is what is really new, and I wanted to share in terms of neurorehabilitation. As you can see in the center, that you have, if you have an electronic medical record, for example, you can extract the data. You can use your electronic platform to look at the supported shared clinical decision making, and you can see how you evaluate that, or if you implement a change, and how you can reassess that. So basically, it includes 3 processes, which really means you're applying knowledge to practice, practice to data, and data to knowledge. And this is a very good system on driving improvement in a hospital for safe, effective, patient-centered care, including the community. And this is the model that we're currently using in a big research implementation study, where we have implemented a battery of tests for rehabilitation assessments, which include ClinFit, EQ5D, and community integration measures and others. And then we extract the data live to look at what is happening so we can make changes while they're still happening, not waiting for that some weeks down the track and then implementing a change. It's instant. And we have a dashboard, almost clinical dashboard on the computers that tell us, for example, patients are waiting for social work input or nutrition or dietetics input and so forth. And basically it helps us to extract clinically relevant information, which includes risk stratification. And this is really important in terms of quality improvement initiatives, where it helps you identify gaps in clinical care, timely care, community referrals and requirements, and what are the barriers, and it's a very sustainable process. So I just wanted to share this with you. Hopefully when the project is completed, I can present the findings to you at a later stage. What this has allowed us to do is to have rehabilitation, multidisciplinary, transdisciplinary clinics interfacing with palliative care, ambulatory care, which is community care, with family doctors and other specialist treatments, clinics, and also community wellness programs, so that, for example, a person who may have brain tumors for whatever lifespan they have following treatment, definitive treatment, they can have their functional assessments, they can have the complication action plan in place, they can have the whole range of disability prevention strategies, including community-based rehabilitation and empowerment. And then as they progress down the trajectory, palliative care, supportive care, health maintenance and other initiatives can be initiated at the same time. This is very much in line with our nationwide cancer rehabilitation services, and neurorehab is brain tumors and other spinal tumors, for instance, could follow this patient care pathway. Another example we have is at Royal Melbourne Hospital, we have at-home care, which really looks at the step, which is safe, timely, effective and patient-centered care. We have both aged care and rehabilitation services for neurorehabilitation that provide in-home care to patients free of charge. And when we look at orthopedic or musculoskeletal or acute stroke populations, for example, then stroke populations are classically good for this at-home service. And on the right-hand side, you will see the SWOT analyses, which show many strengths of this program, as you can see listed in this first square. But there are also many weaknesses. And the weaknesses include, for example, IT issues or staff training or lack of marketing, or the service may be too small for the number of referrals they're getting. That is our particular problem here. What are the threats to this sort of service? For example, consumer knowledge. Do the patients know of these services? Do the GPs know and they can refer appropriately? Staff have to go into patients' homes. It's safe for them to do that. Or can we broker other services which may not be part of a generic at-home service, such as speech pathology? And there are many opportunities to do this really well, because in our particular hospital, we have a lot of executive support. We have partnerships with our family doctor GP networks and community organizations, and it really enables a broader service structure for the hospital, and we can improve personalized care to our patients. Another example is of younger persons transition program service in the community. This model is called Transitional Care Program for rehabilitation. It's only for people under 65, those who have, for example, a neurological disability. And basically this program brokers services in the community till the person will go home. For example, they will require home modification, ramp building, for instance, or changes in the bathroom or the kitchen to enable the patient to transition home, but they don't have any medical needs which would allow them to be admitted in a hospital. So this is a temporary 3-month program that we also run, funded by the Department of Health. I'd also like to talk lastly about the partnership model, which we started during the COVID pandemic at the request of the Department of Health, where we looked at a number of health services like Mercy Health, Western Health, the Royal Melbourne Hospital and others, which provided clinical input, including an Aboriginal health service, which you can see the Derewa Health Services. We then went into partnership with Co-Health, which is all about social and welfare and supportive care. And then we looked at the Northwestern Melbourne network, which looks at policy, legal and technical framework in partnership with the Department of Health Victoria. And this is currently being evaluated, but it's really a good model also when you want to look at your virtual hospital, telehealth services, and to expand the current services virtually. There are many challenges we identify in rehab care continuum for neurorehabilitation, and some of them are listed here. For example, there are knowledge barriers, lack of understanding of referring doctors, neurologists, perhaps rheumatologists and others who may not be fully aware of what the rehab medicine care continuum could contribute to patient care. We need a skilled workforce, we need partnership, we need advocacy at the government level with policy and planning. We need sustainable facilities and accessible health systems so patients can access care easily where possible, and ideally it should be affordable. There are many issues with the adherence that were identified with many of the projects we've done, such as convenience and access to health services, patients' fear of injury, ability to participate or to self-manage their healthcare. Health literacy is a really important factor here. There are lots of stigmas such as discrimination against disabled persons or social stigmas. And then, of course, the biggest challenge for us in Asia Pacific is the health insurance. Not every country has a health insurance, a universal healthcare system. I know countries like Thailand, Indonesia are doing really well, and others, but many countries are still struggling with providing affordable healthcare to their citizens. Pascal? It's done.
Thank you very much, Professor Fari. That is very interesting. A look-see into the system of a developed country, which is Australia. And you can see that there's a linear progression from rehabilitation to the community, and also a 360-degree addressing of problems, management by all the staff and all the caregivers involved in the patient's care are looking towards the patient in a 360-degree view. We are entertaining
You can write
questions.
your questions in the question answer, please, if anybody has.
Yes, yes, and we will read your questions.
I don't see at the moment any question.
I have a question for you, Nirmal. Is there a
Yeah.
trend of decreasing numbers of neurorehabilitation disorders in Asia Oceania? Or is it still
No,
dismal, or is it increasing in numbers?
the global burden of disease, which has studied and a huge population, which is over a period of 2009 to 19, 10 years data, which clearly says that there are certain neurological disorder are on increasing trend. The better the lifestyle of the country, so particularly country like China, whose GDP has improved, the lifestyle is better. There, the incidence of stroke, Alzheimer's disease, and Parkinson disease is increasing. India is also following the same path. So as we are moving away from the low to the middle income country to the lower middle income country, the disease burden is getting changed from infection, the birth disorder, the genetic disorder, to the non-communicable disorder. So non-communicable diseases are the one which is increasing in incidence, and we are following the West. Also, the age has increased, so longevity has increased. In every country where the longevity has gone beyond 75 years, the degenerative disorders are going to be seen more. So the incidence is obviously going to increase.
Because of the aging population. Do you want to comment, Dr. Abhishek?
Yeah,
Do you have
another
any
question for
comments
Dr.
or questions
on the
about
similar line.
this?
Yeah.
Yes, on
So
this
question
trend
for-
of neurorehabilitation.
The question for Dr. Surya on similar lines. We have two types of brain disorders, the progressive ones and the non-progressive ones. So how the rehab challenges are different in both the populations and what we should take it forward in the long term.
All right. So see, the need for both the disorders are different. Progressive disorder needs an intervention at different places, because now, like suppose Alzheimer's disease, which is a progressive disorder, or the Parkinson disease, which is a progressive disorder. Now today, the cognitive impairment may not be the bad, but after 6 months, her behavior problems or aggressiveness could be worse. And after 1 year, there may be a different scenario. And therefore, the person may not be able to feed herself or take activity of daily living. So you need to modify the plan of the treatment as per the change in the progress of the disease. Similarly, MS, you have a relapsing remitting illness. Patient is all right, going to office, suddenly she get another relapse and goes into the bed and then remain in the bed for 6 months. So the need of treatment depends on acute treatment during the relapse as well as long-term monitoring of these patients. While the chronic progressive like disease like MND, where you are not, you know that disease is progressing slowly over a period of time, and you know that no treatment is available, you can plan out, okay, at what point of time I will need a respiratory assistant, at what point of time I think I need to have a feeding thing. So that can be planned in a different way as compared to the disease which are progressive or which are intermittently coming, remitting and relapses. So that, and then stroke. Once the stroke has happened, they start improving. So over a period of time, again, the need and requirement could be entirely different.
Thank you.
That's why it's so challenging. All these rehabilitation disorders, their management is challenging because it's dynamic. So you should have dynamic solutions to all
couple
these
of
problems
questions.
of these patients. Yes, we have from
Ireland.
Dr. Aisha Khan. It's a comment. Thank you very comprehensive. We also have early support discharge MDT teams in Ireland who reduce inpatient stay, duration, and facilitate discharge to community. Thank you very much, Dr. Khan. And
That's
from
wonderful. That's wonderful
Dr.
to know.
Yes, wonderful. Dr. Eufrasio Pacañas Jr., I've worked in a pediatric clinic in Saudi Arabia that specializes in treating different types of CP. They are practicing what they call the conductive therapy together with oxygen therapy through hyperbaric machine. Is this approach undergone studies and proved to be effective?
Also, Abhishek is got a lot of experience on
So-
SBOT, particularly he has got 2 or 3 machines.
MDT.
He can comment on that.
Yes, so there are approved indications for hyperbaric medicine to be used in rehabilitation. And right now, cerebral palsy or autism are not approved indications for HBOT for promoting recovery. Only patients with massive brain injury, with hyperfusion injury, with hypoxic encephalopathies, massive stroke, massive TBI, those who have cerebral edema, require decompression surgeries, those patients can still be tried, but pediatric indications, especially autism and cerebral palsy, are not being approved till now for HBOT in clinical practice.
The only thing I don't like about the hyperbaric treatment is that it raises the expectations of the parents too
Yeah,
high
it's too
with the
high.
children. So that really has to be discussed very well with the parents before it becomes an option for the children. Anyway, you go to the next one from Anil Hawa Ibrahim. Stroke is a condition that needs continuum care. We agree. Who should lead and coordinate or champion the care at all levels, acute, subacute rehabilitation community, so that every level understands the importance. Thank you. Would you want to answer, Nirmal?
Yeah, Mr. Ibrahim, I think it is very important, as you rightly pointed out, the stroke, the rehabilitation start in the ICU, then goes into the high density unit, then of course into the ward, then into the community and into the family. And therefore, the person who start the treatment right at the beginning need to take the team together depending on what stage they are dealing with the patient. And it is the team who should keep on switching from one person to another depending on the need and the disability of the person and their family, because this is how it should be planned, and this is what we do here in India also. And the best result you can obtain is when your team works with the patient and the family and caregiver to get the best out of it. And I completely agree that it cannot be one plan. It has to be planned different at different place, and individual has to be tailor-made. Thank you very much.
Okay, we'll continue. Wonderful session. AOSNR, IFNR. Thank you for such an informative webinar. Looking forward to the further webinars from Pushkrab Marne and from Candice Xiao Yugo with advancing
I want to say
technologies
that
like using
we got a very dynamic team now at the AOSNR. We got President, of course, myself, but Secretary with Sonu, the President-elect Ferry Khan, and the past President Joy is there. And then we have a scientific chair, Abhishek. So we are definitely going to bring you the scientific session. Periodically, we would definitely need you to send us the feedback that what could make a difference, how you would want the future webinars to be done. Kindly note that first Thursday of the month, 3 p.m. Indian time, which can be plus GMT 6, you could note down. The next session will be on 6th of June, again 3 p.m. Indian time. And the theme is how rehabilitation can promote the neuroplastic changes. Again, we'll bring the two speakers and two topics. We'll send you all the detail on that. And I'm sure you can send it to the other people to register themselves. And so that will help. Yeah. Go on to the Candice, Joy.
Candice Xiao Yugo, I hope I pronounced your name properly. With advancing technologies like using AI in your rehab, mostly in developed countries, what are some practical steps we could take to integrate interventions like virtual reality, robotics, and telerehab in resource-limited settings?
Oh, perfect. I think, Candice, you have put up a right point, and we just finished the IFNR annual conference 2 weeks ago, 12th to 14th of April. And we really have come out with low-cost, newer technology. And I must tell you that telerehabilitation is not a high cost. It is a very, very low-cost therapy can be planned out. We are working out on various low-cost robotics. In fact, we had 2 workshops, interestingly, robotic with people from Switzerland and also from India. And we had a BCI workshop, which is entirely made in India. So Make in India, Made in India is really coming out. And not only that, there are many countries like Malaysia, Indonesia, Thailand. They are making some good low-cost technology using the robotics and virtual reality and other. So I think Asia is doing well. It is just a matter of time that we need to have some more rehabilitation specialists working together with our IT guys.
We lost the signal, Professor Surya.
Yeah, Nirmal, you're frozen in the
From each
screen.
country, and that could be a point of the future.
Yes, I believe robotics are going down in cost also through the years,
Yep.
and there'll be innovations in robotics that will make it more affordable in the near future. So let's wait for that.
Right now,
Anyway,
we
we
have
have so
about 3 companies in India who are making
many
robotic
comments
systems for
also.
both upper limb and lower limb. So in India, right now, we have about 3
Yeah,
companies who are making upper
that's
limb and
very
lower limb
good. They're
systems.
very, very good.
And cost is 1/3 of what we normally pay for the European model.
Right. That's good because if you have more manufacturers, then the cost really go down.
Yeah.
So very nice comments on the webinar chat about how they are enjoying this session. Insightful, looking forward, and this has been a very good webinar. Our first webinar. And thank you very,
I have
very
one
much
more
for all
question
of your
is Ishita
participation.
Chaudhary. Joy, there's Ishita Chaudhary.
Yes,
has,
Nirmal.
how to integrate virtual reality with EJ.
Sorry.
So
Sorry.
Ishita,
There's one more.
the 2 weeks ago, there was a conference which was held in China on the brain-computer interface. And there are a couple of projects, and I just want to tell you that I am on the Government of India panel for the standard of brain-computer interface, and I'm one of the WG1 member who is part of the BCI. So I have attended the online conference after coming on 14th from the Pondicherry, and there are a lot of work is been happening in BCI with virtual reality and EEG, how they're changing the signals and these all are, of course, getting into the research at the moment. But I can tell you that in next 1 or 2 years, there are some new gadgets will come which will help the visual impairment people, the cognitive people to help and understand and read, because they are coming out into the app which can decode the things, how the brain is interpreting, and give the person through the virtual reality the proper vision. So things are changing, and I mean, these are something which is IT guys and engineers are working. So it's beyond me also, but I'm trying to understand. 300 channel EEG is what they've been working on. So these are highly, highly advanced EEG system which can detect things from the brain. So yes, your question is valid, but BCI will change this. Thank you.
Okay, so this is, for some, it's their introduction to AOSNR. We invite you to be members of AOSNR. You have to be a member first of your local society. And if they are members of AOSNR, then you're automatically also members of AOSNR. So do you have any last words, Professor Nirmal, our president?
So, I thank you very much, Professor Joy and Farid Khan, and I also thank Abhishek Srivastava that this is the first activity of AOSNR under my presidency. I have taken 3 months to come out of this. December I have taken over, but I promise you that this will continue. We will come out with some new innovation, and I really need you guys to push me up what you really want and how we can enhance the research, education, training, not only in this part of the world, but all developing countries across the world. I'm very happy. You can always send me an email and you can also send your feedback. Asmita, if you can share the AOSNR email so that they can write to AOSNR. But you can also write to me, nirmal_surya@yahoo.com. Very simple. Thank you very much.
Okay, there's an important question here. Do they get certificates for this session? Do they, or is for the whole
we
webinar
will
series?
give everybody, if they attend all the session, we'll try and give a certificate for attending the webinar. 1 year certification.
Okay. Yes. 1 year.
Yes.
Okay,
Please
thank
join
you
all
very
the
much,
webinar.
Nirmal. Thank you, Abhishek.
Thank you. Bye-bye. See you next.
If there are no further questions, we thank
Bye,
everybody.
Sue.
Bye. Yeah. Bye. We'll end the session. Thank you. Thank you very much.
Thank you, everybody.
Bye.